Imagine trying to support a sagging ceiling with this massive, heavy steel beam. You get the beam perfectly sized, right? You wedge it into place. But there is this one critical flaw you completely didn't account for.
The walls holding it up.
Exactly. The walls holding that beam up are actively turning to dust. The actual structure you are relying on for support is, well, it's fundamentally changing its physical properties. And that exact biomechanical nightmare is actually the daily reality facing up to 50% of women.
It is such an incredible visual. I mean, it captures the structural crisis perfectly because in medicine, we really love a static equation,
Right, like X plus Y equals Z.
Exactly. You find a structural weakness, you apply structural support. Simple. But when you step into the world of women's health and pelvic biomechanics and aging, you quickly realize you're dealing with a physical landscape that is, well, a constantly moving target.
Welcome to the Deep Dive. Today, we are exploring a really fascinating intersection of anatomy, aging, and, honestly, mechanical engineering. We've got a robust stack of clinical guidelines in front of us today.
Yes, we are pulling from documents from the National Institute for Health and Care Excellence, the British Menopause Society, and the Pelvic Obstetric and Gynecological Physiotherapy Group.
Right. And our mission today is for you to understand one critical question. Can the microscopic structural changes that happen in vaginal tissue during menopause actually change how a medical device, specifically a vaginal pessary, fits, feels, and functions?
And the short answer is absolutely yes. But to truly understand the mechanics of why a perfectly designed device suddenly fails, we first need to look at the baseline problem it's trying to solve.
Right. So let's talk about pelvic organ prolapse. Going through the sources, the gravity of this condition, and I mean literally gravity, is staggering. We're talking about half of all women experiencing this.
It's extremely common.
Yeah, because the female pelvis relies on this very complex support hammock of muscles, ligaments, and connective tissue to hold the bladder, the bowel, and the uterus in their proper anatomical positions.
Exactly. And over a lifetime, that support hammock takes a serious beating, whether it's from the massive physiological strain of pregnancy and childbirth, or even chronic conditions that increase intra-abdominal pressure.
Like heavy lifting.
Yeah, heavy lifting, chronic coughing, severe constipation. Over years, those ligaments and muscles can stretch and weaken. And when that structural integrity fails, gravity wins. One or more of those pelvic organs physically drops down, bulging into the walls of the vagina.
In reading through the clinical pathways, the daily reality of living with a prolapse sounds incredibly disruptive. I mean, women report this constant, heavy dragging sensation, a physical bulge that they can actually feel.
Yes, and lower backache, too.
Right, and severe functional issues, like having to physically push the bulge back up just to empty their bladder or bowels. It pretty much completely hijacks your quality of life.
It really does. Now, historically, the immediate thought is surgery. Let's go in, reconstruct the ligaments, and basically tack everything back up. But surgery carries significant risks, requires extensive recovery, and critically, prolapses have a very high rate of recurrence, even after a surgical repair.
Oh, wow. So even if you fix it, it can just happen again.
Exactly. So surgery isn't always the first choice, and for many, it's not an option at all.
Which brings us to the mechanical scaffold, the vaginal pessary. A pessary is a removable intravaginal medical device, typically made of medical-grade silicone. Its sole purpose is to act as a physical prop.
Right. A support beam.
Yeah. You insert it into the vagina, and it physically holds those prolapsed organs back up where they belong, which instantly relieves that dragging pressure. But looking at the POGP guidelines, these devices are wild. They aren't just one standard shape.
Oh, far from it. They come in a staggering variety of shapes and sizes because every pelvic floor defect is uniquely shaped.
Right. There are ring pessaries, which look exactly like they sound, just a flexible silicone hoop. But then you have cube pessaries, which look like little silicone dice that literally use suction against the vaginal walls to stay in place.
Yeah, the mechanics vary wildly depending on the type of prolapse.
And there are dish pessaries with specialized knobs to support the urethra if a patient has incontinence. And these things called Gellhorn pessaries, which look almost like a suction cup attached to a stem.
I have to admit, looking at the diagrams, I kind of assumed finding the right one was like finding the right shoe size. You know, you measure the space, pick the device off the shelf, and you're good to go.
I really wish it were that simple. Fitting a pessary is notoriously an art, not just a science. The vagina isn't a rigid PVC pipe. It is a highly dynamic, flexible, muscular space. The clinical guidelines clearly outline that finding the correct pessary relies heavily on trial and error.
Which honestly sounds a bit exhausting for the patient. The guidelines say it takes an average of 2 to 3 separate clinic fittings just to get the size and the model right. Yes, and the margins for error in that fitting process are incredibly slim. The clinician has to estimate the size based on a physical exam. If they choose a ring that is even slightly too small, it lacks the tension to grip the muscular walls.
So what happens then?
The moment the woman stands up, coughs, or goes to the bathroom, the device literally falls out.
Oh, geez. And on the flip side, what if the clinician overcompensates and puts in a pessary that's just a few millimeters too large?
Then it places excessive constant pressure on the vaginal walls. That causes severe radiating pain. A proper fitting requires the patient to walk around the clinic, sit, stand, and pass urine before they are even allowed to leave.
Just to make sure it's perfect.
Exactly, just to ensure the silicone scaffold is perfectly calibrated against healthy, flexible tissue.
And there's the operative phrase, right?
Mm-hmm.
Healthy, flexible tissue. Because if that perfect fit relies on the tissue acting like a flexible, resilient cushion, what happens when the biology itself decides to radically change the floor plan?
That is the big question.
Looking at the British Menopause Society documents, we run headfirst into a condition called genitourinary syndrome of menopause, or GSM.
Right. GSM is the internationally accepted comprehensive term for what clinicians used to call vulvovaginal atrophy. It describes the total transformation of the urogenital tract driven by long-term estrogen deficiency.
Which happens naturally during menopause.
Exactly. To really grasp why a mechanical device like a pessary suddenly fails in a postmenopausal environment, we have to zoom in on how this estrogen drop dismantles the tissue architecture layer by layer.
Let's pull that apart because the anatomy here is fascinating. The vaginal wall isn't just one type of skin. It actually has 3 distinct layers. You've got the mucosa on the very inside. That's the surface the pessary actually touches.
Right.
Underneath that is the muscularis, which is the smooth muscle that gives the vagina its contractile strength and tone. And then on the outside is the adventitia, a connective tissue layer that anchors the whole structure to the surrounding organs.
That's right. And in a premenopausal state where estrogen is abundant, that inner layer, the mucosal epithelium, is thick, robust, and highly active.
Just constantly regenerated.
Exactly. The superficial cells of this lining are constantly shedding and replacing themselves, almost like a localized exfoliation process that happens every few hours.
But according to the BMS data, the moment estrogen production drops off during menopause, that entire inner mucosal layer practically starves itself. It completely changes its behavior.
It does. Without estrogen binding to the local receptors, the cellular turnover just grinds to a halt. The mucosal layer becomes drastically thinner. In fact, those superficial epithelial cells stop shedding at their normal rate until they make up less than 10% of the tissue.
Less than 10%. That's a massive drop. So the padding is just gone. But what really blew my mind in the research is the cascade effect this has on the local microbiome. I always assumed the thinning tissue was just a structural problem, like it just gets thin. But the lack of shedding actually triggers a massive chemical change.
It's a brilliant, if unfortunate, chain reaction. In a healthy state, when those superficial cells shed, they release large amounts of a stored sugar called glycogen. Glycogen is essentially the primary food source for lactobacilli.
And those are the good bacteria.
Exactly, the dominant healthy bacteria in the vaginal microbiome.
Right. And those lactobacilli feast on the glycogen and produce lactic acid as a byproduct. And that lactic acid acts as a chemical shield, keeping the vaginal pH perfectly acidic, usually around 3.5 to 4.5.
Spot on. But let's follow the GSM cascade. No estrogen means no cell shedding. No cell shedding means no glycogen is released. And no glycogen means the good lactobacilli literally starve to death.
Wow. And without the lactobacilli pumping out lactic acid, the vaginal pH spikes above 5. The environment completely loses its acidic shield and becomes alkaline.
Which throws the doors wide open for other commensal organisms, particularly gut bacteria like E. coli, which can then colonize the space. This dramatically increases the risk of abnormal discharge, chronic irritation, and recurrent urinary tract infections.
That sounds miserable.
It is. But the structural deterioration doesn't stop at the mucosal surface. It goes much deeper, right into the connective tissue supporting the muscularis layer.
Okay, this is where we get into the fibroblasts. The guidelines highlight these little cellular factories.
Yes, fibroblasts are the cells responsible for producing collagen. That's the structural protein that gives your tissues their tensile strength. And they also produce elastin, the protein that allows tissues to stretch and snap back.
Right.
Postmenopause, without estrogen to stimulate them, these fibroblast factories essentially board up their windows, they go completely dormant and turn into inactive cells called fibrocytes.
So they just stop producing new structural proteins entirely.
They do. And the existing collagen fibers begin a process called hyalinization. They fuse together, losing their organized structure and becoming very rigid. Meanwhile, the elastin fibers physically fragment and break apart.
And the macro result of all this microscopic breakdown is that the vagina literally loses its rugae. For anyone unfamiliar, rugae are those natural corrugated folds in the vaginal tissue. Kind of think of the bellows of an accordion.
That's a great way to picture it.
They allow the vagina to expand immensely. And, crucially for our topic, they provide a textured surface for grip.
Precisely. Without elastin and without those accordion-like rugae, the vagina becomes shorter, significantly narrower, and completely smooth. Because the local blood supply also diminishes without estrogen, the tissue turns pale and becomes highly friable.
Friable.
It's a clinical term, meaning it tears or bleeds with very minimal friction.
So putting this all together, we aren't just looking at a minor change in moisture. The internal environment is fundamentally transforming from a flexible, thick, moisture-rich memory foam into a thin, dry, and incredibly fragile piece of parchment paper.
That analogy hits the nail on the head. You are losing the padding, the elasticity, the grip, and the structural integrity all at once.
So if the tissue is now fragile, dry parchment paper, what exactly happens the moment you introduce a rigid, medical-grade silicone ring into that space?
This is where the mechanical solution and the biological reality violently collide. The pessary is designed to sit firmly against the vaginal walls to hold up the prolapsing organs. But because those walls are now pale, friable, and lack any natural lubrication, the friction from the silicone is relentless.
It's literally just bone-dry silicone scraping against paper-thin skin.
Yes. And the clinical results outlined in the guidelines are severe. The pessary causes acute excoriation. It rubs the tissue raw, creating painful abrasions and ulcerations.
Ulcerations, like open sores.
Exactly. Open, crater-like sores inside the vagina. The British Menopause Society notes that simply examining the tissue might reveal petechial hemorrhages, which are tiny pinpoint bleeds under the surface, just from the minor trauma of the device resting there.
Oh my God. But wait, let me push back on this. If the tissue is literally tearing and creating open sores, doesn't that inherently change the physics of the device? I mean, if the vagina is now shorter, narrower, and completely smooth because the gripping rugae are gone, how does a pessary even stay in place?
That is the exact biomechanical failure clinicians encounter. A pessary size or shape that might have fit perfectly and comfortably just a few years prior will suddenly fail completely. Because the tissue has lost its elasticity, it can no longer stretch to accommodate the device.
Right.
So a pessary that used to fit easily will now cause excruciating pain because the walls physically cannot yield to it.
Or because the gripping folds are gone and the space is narrower, the device just slides right out. The scaffold completely loses its foundation.
Exactly.
But here's my real question. If a patient is dealing with open ulcers, bleeding, and a device that either hurts immensely or falls into the toilet every time they pee, wouldn't they just abandon the non-surgical route? Wouldn't a patient just say, forget this piece of plastic, I'll take my chances with the surgery?
Unfortunately, yes. It happens constantly. Women abandon a perfectly viable, non-invasive treatment simply because the biological side effects of the device become unbearable. But, and this is a vital point in all the clinical pathways we reviewed, abandoning the pessary isn't the only option. And frankly, it shouldn't be the default. You don't have to jump straight to surgery.
But how do you fix it? You can't change the silicone, it's a fixed material.
Right. You can't change the mechanics of the silicone, so you have to structurally rehabilitate the biological environment. You have to turn the parchment paper back into memory foam.
And according to the guidelines, the way you do that is by introducing local hormones. Specifically, they advocate for topical treatments like vaginal estrogen creams, tablets, or DHEA pessaries. Now wait, I have to stop here, because the moment a patient reads estrogen on a prescription box, alarm bells are going to ring. We've all heard the massive systemic warnings associated with hormone replacement therapy, HRT. If estrogen is known to drive certain types of cancers, how is putting it directly into the vaginal tissue not carrying the exact same massive risks as systemic HRT? I imagine a patient being terrified by that recommendation.
That is an incredibly common and completely understandable fear, but it's a massive misconception. The POGP and NICE guidelines draw a very hard, thick line between systemic HRT and local vaginal estrogen. Systemic HRT, like the pills or patches, puts hormones into your bloodstream to circulate throughout your entire body.
Right.
Vaginal estrogen treatments are ultra-low dose and act purely locally. The absorption into the general bloodstream is negligible, keeping it within normal postmenopausal ranges.
So it's essentially a topical skin cream just for an internal surface.
Ex-
But the treatment that really caught my attention in the guidelines was the use of DHEA, specifically a daily vaginal insert called prasterone. The mechanism behind how this works is called intracrinology, and it is frankly one of the most elegant biological processes I've ever read about.
Intracrinology is a total game changer. Let's break down why it's so brilliant. When you insert a DHEA tablet into the vagina, the DHEA itself is completely inactive. It does nothing on its own.
Wait, really? It's inactive?
Completely. But the vaginal epithelial cells contain specific, highly specialized enzymes. When the inactive DHEA enters those cells, the enzymes grab it and convert it into active estrogens and androgens right there, entirely within the cell itself.
Oh, wow. It turns the local tissue into its own private manufacturing plant. The active hormones are created exactly where they are needed, down to the microscopic level.
Exactly. And here is the aha moment, the real genius of this system. Once those locally manufactured hormones do their job of repairing the cell, 95% of them are deactivated right there at the site of synthesis.
So they don't even get into the bloodstream.
Right. They are neutralized before they can ever cross over into the general bloodstream. It's like a targeted, smart drug delivery system that leaves basically no systemic footprint.
That is amazing. It completely circumvents the systemic risks while providing profound local healing. So what happens when these local hormones, whether from a low-dose cream or intracrene DHEA, go to work?
We see a rapid total reversal of the GSM cascade. The local hormones stimulate the mucosal cells to start shedding again. The shedding brings back the glycogen. The glycogen feeds the lactobacilli. The lactobacilli produce lactic acid, restoring the acidic pH and immediately driving away the E. coli.
It's like restarting the engine.
It really is. The epithelium physically thickens and rebuilds its padding. The blood supply returns, bringing oxygen and turning the tissue a healthy, robust pink again.
And those boarded-up fibroblast factories.
The localized androgens wake them right back up. They convert back from dormant fibrocytes into active fibroblasts and start furiously pumping out new collagen and elastin, which drastically increases the tissue's density and stretch.
You know, it's exactly like applying a specialized deep-penetrating wood conditioner to dry, cracking timber before you try to drive a heavy structural screw into it. If you just try to drill into dry rot, the whole thing splinters and fails.
Yeah.
You have to restore the material's structural integrity first so it can actually handle the mechanical load of the screw.
I love that analogy because it emphasizes the preparation phase. You absolutely cannot divorce the mechanical device from the biological tissue. And the clinical pathways reflect this perfectly. The POGP guidelines are emphatic. If a patient is postmenopausal, clinicians are highly encouraged to prescribe vaginal estrogen to be used daily for 7 to 10 days prior to a pessary fitting or a scheduled device change.
That prep phase is crucial. It gives the wood conditioner time to heal any existing microscopic ulcers, thicken the lining to withstand the impending friction, and ensures the actual clinic appointment to size and fit the silicone device is significantly more comfortable and successful. It bridges the gap between the mechanical scaffold and the biological foundation.
Right. It requires a completely holistic view of pelvic biomechanics. You are treating the structural prolapse and the biological atrophy simultaneously as two halves of the exact same problem.
Now, before we wrap up, I want to pivot because there was one tiny detail buried in the British Menopause Society source that really fascinated me. We've spent this entire time talking about how chemical intervention, like local estrogen or DHEA, is the primary line of defense to reverse tissue atrophy.
Yes, it is definitely the gold standard for clinical treatment.
But the sources briefly highlight a purely non-chemical factor. They specifically note that regular sexual activity physically improves blood supply and, quote, causes mechanical stretching of the tissues, which helps maintain elasticity, reducing progression of GSM. This totally changes the paradigm if the tissue responds to physical load.
This is a massive concept. What you are describing is mechanotransduction. It's the biological process where cells actively sense physical strain or mechanical forces and translate those physical cues into biochemical responses.
Right. So a mechanical stretching physically tells the tissue to maintain its elasticity and promotes blood flow. Could we look at a future where targeted physical therapy becomes a primary prescription for reversing atrophy? I mean, if you don't have regular sexual activity, could the active use of vaginal dilators or specialized mechanical stimulation wake up those fibroblasts just as effectively as a hormone cream?
It's an incredibly provocative thought. We already know that physical therapy and weight-bearing exercises are mandatory for maintaining skeletal muscle and bone density as we age. The body operates on a use it or lose it principle, right?
Yeah, absolutely.
So if the vaginal walls, specifically the muscularis and the collagen-producing fibroblasts, respond to mechanical stretching by actively maintaining their structural integrity, we might be looking at a future where mechanical rehabilitation is prescribed alongside or even before localized hormones.
It implies that the body has this incredible latent capacity for self-repair, provided we give it the correct physical stimulus. It means the tissue acts like memory foam, and we might be able to keep it bouncy simply by actively working it.
It completely reframes how we view aging tissue. It's not just a passive structure deteriorating over time. It's a dynamic, responsive material that actively adapts to the loads placed upon it.
So we started this deep dive by saying that treating pelvic organ prolapse wasn't as simple as engineering a bridge. But the deeper we go, the more it seems like maybe it is. Maybe the vaginal tissue isn't just the passive ground the bridge is built on. Maybe the tissue is a dynamic, intelligent material that actually gets stronger the more you safely test its load. If mechanical stretch can trigger cellular repair, it opens up a whole new frontier for how we approach women's health and aging. Something for you to mull over long after this deep dive ends. Until next time, keep questioning the mechanics of how things work.